You probably heard of Ozempic, maybe you've taken it, maybe someone you know is on it. Maybe you've seen the before and after pictures on Instagram and wondered if you should ask your doctor about it. Here's what I need you to understand before this video goes any further. GLP-1 medications are generally powerful. They are not just hype. They have clinical data behind them that is honestly remarkable. But the way most patients are being started on these medications, without the right education, without the right monitoring, without anyone explaining what is actually happening inside their body, that is a problem. And the reason it's a problem is not because the drug is dangerous, it's because we're handing people a powerful clinical tool and sending them home with almost no instructions. I'm Nimata, I'm a clinical pharmacist, and for the next 10-15 minutes of this video, I'm going to tell you everything your doctor just probably didn't have the time to explain to you, and a few things I don't think anyone told you at all. Let's get into it. First, what is GLP-1? GLP-1 stands for glucagon-like peptide 1. It's a hormone. Your body already makes it. It's released from cells in your gut after you eat, and it does a few very specific things. It tells your pancreas to release insulin, but only when blood sugar is actually elevated. It tells your pancreas to suppress glucagon. Glucagon is the hormone that tells your liver to dump sugar into your bloodstream. So GLP-1 is working on both sides of the equation. And then, this is the part that most people don't know. It crosses into the brain, specifically into an area called the hypothalamus. And it slows gastric emptying, meaning food moves more slowly out of your stomach, and it reduces appetite signals at the neurological level. This is why people on these medications don't feel hungry the way they used to. It's not willpower, it's not discipline, it is a direct pharmacological effect on appetite, regulating circuits in the brain. Now, the medications. Semaglutide, that's Ozempic for diabetes, Wegovy for weight loss, is a GLP-1 receptor agonist. Tirzepatide, that's Mounjaro for diabetes, Zepbound for weight loss, is a dual agonist. It hits GLP-1 receptors and GIP receptors, which is why the weight loss data on tirzepatide is frankly more impressive than semaglutides. Liraglutide is Victoza, and Saxenda is an older GLP-1, still used, just less frequently now. These are not the same drug. The mechanism is related, but the clinical profiles are different. And your prescriber should be matching the medication to you, not just prescribing whatever is trending at the moment. Now, I'm not here to trash your doctor. The physicians I work with and know are brilliant people who are under impossible time constraints. The average primary care visit in the United States is 7 to 15 minutes long. In that time, your doctor is supposed to review your chart, address your reason for the visit, make clinical decisions, document everything for liability purposes, and explain a complex medication to you. It doesn't get done, not because doctors don't care, it's because the system doesn't give them time to. So what does a typical GLP-1 conversation look like? Looks like this. Your A1C is elevated. I'd like to start you on a semaglutide. We'll begin at a low dose and titrate up. You may have some nausea at first. Here's a prescription. See you in 3 months. That's it. That's the entirety of the education most patients receive about a medication that is fundamentally changing how their body processes food, regulates hunger, and manages blood sugars. And again, I'm not blaming the physician, I'm naming the gap, because that gap is exactly where bad outcomes live. Okay, here's where we get into it. 3 things that most patients on GLP-1 medications are not being told, and that genuinely matter for their outcomes. Number 1, muscle loss. GLP-1 medications cause weight loss. That is not under debate, but here's what nobody's putting in the pamphlet. A significant portion of that weight you lose on a GLP-1 can be lean muscle mass, not just fat. Studies on semaglutides have shown that roughly 25 to 40% of that weight loss during treatment can come from lean tissue. Let me say that again. If you lose 30 pounds on Ozempic, somewhere between 7 and 12 of those pounds might be muscle, not fat. Why does this matter? Because muscle mass is not just about how you look. Muscle is metabolically active tissue. It drives your resting metabolic rate. It protects your joints. It is one of the primary determinants of long-term metabolic health. Lose enough of it and you set yourself up for a phenomenon some researchers are calling Ozempic rebound, where patients who stop the medication regain weight rapidly, partly because their metabolism has been altered by the loss of lean tissue. What's the fix? Resistance training. Not optional, essential. And adequate dietary protein. Not some protein, deliberate tracked protein intake. The clinical guidance I give patients is 0.7 to 1 gram of protein per pound of body weight per day, and some form of resistance training, even body weight, at least 3 times a week. Number 2, the medication is buying you time, not building you health. This is the one thing that I think matters most physiologically. GLP-1 medications work while you take them. The appetite suppression is pharmacological. The metabolic effects are pharmacological. When the drug is gone, and for most patients at some point it will be gone, the underlying behaviors, habits, and metabolic environment that got you to the starting points are still there, unless you use the window the medication gave you to actually build different habits. This is not a knock on the drugs. This is the most important thing that I can tell you about them. A GLP-1 is a runway. It gives you reduced appetite, improved blood sugar control, and real clinical benefit while you do the harder work of restructuring your relationship with food, building a movement practice, and addressing whatever drove the metabolic dysfunction in the first place. The patients I see getting the best long-term outcomes on GLP-1s are not using the medication as a solution, they're using it as an on-ramp. The medications I see struggling are the ones who regain weight, whose A1C climbs back, who feels like the drug stopped working. These people are often the ones who were never told this. They treated the medication as the entire answer because nobody framed it as a tool. Number 3, the monitoring. That's often not happening. When a patient starts a GLP-1 medication, there's a set of things that should be happening on an ongoing basis. I'll be specific. Kidney function. GLP-1s have nephroprotective data, particularly in CKD patients, but renal function still needs to be monitored, especially as patients lose weight and their medication dosing may need to be adjusted. Thyroid. There's a contraindication to GLP-1s in patients with a personal or family history of medullary thyroid carcinoma or MEN2 syndrome. This should be screened before initiation, not always happening. Pancreatitis risk. GLP-1s have a known association with pancreatitis. Patients with a history of pancreatitis or gallbladder disease need to be counseled and monitored. Upper abdominal pain that radiates to the back on a GLP-1, that needs to be evaluated the same day. Heart rate. GLP-1s can cause a modest increase in resting heart rate. In most patients, this is clinically insignificant. In patients with certain arrhythmia histories, it's worth watching. And nutritional status. Patients on GLP-1s are often eating dramatically less, significantly less. Without proper attention to nutrition density, you can be losing weight and becoming nutritionally depleted simultaneously. B12, iron, zinc, protein, these need to be on the radar. This is the monitoring list. This is what should be happening at follow-up visits. And this is exactly the kind of oversight that falls through the crack of a 10-minute visit. Let me be clear about something. The question is not, are GLP-1s safe? The FDA-approved indications exist for a reason. The clinical trials are robust. The question is, are they right for you? And are you being managed properly on them? Here's why I made this video. I work at the intersection of pharmacist-led care and chronic disease management. And the number of patients I speak with who are on GLP-1 medications and have never had a thorough medication review, who have never had someone sit down with them and go through their entire health picture, is genuinely alarming to me. Not because their doctors are failing them, because the system isn't built to support this level of medication education. The 15-minute appointment with your doctor cannot hold everything. It was never designed to. This is what clinical pharmacists exist to do. We are the medication experts on your care team. We are not here to replace your physician. We are here to fill the gap between the prescription and the outcome. If you're on a GLP-1 medication and you have not had a comprehensive medication review, talk to a clinical pharmacist. Ask your doctor for a referral. Ask your insurance about medication therapy management benefits. You likely have these and have access to them, but you just don't know it. And if you're watching this as a clinician, as a physician, a PA, and NP, and you're thinking about what better GLP-1 management looks like in your practice, I would genuinely love that conversation. Link is in the description section for a free medication review. GLP-1 medications are not magic. They are powerful, evidence-based clinical tools that work best when paired with the right education, the right monitoring, the right lifestyle infrastructure. The medication buys you time. What you do with that time, that's yours to build. If this video helped you understand your medication better, share it with someone who's on one of these drugs and hasn't had this conversation. That's the whole reason I made it. I'll see you next time.